Welcome to the Testing Psychologist podcast, episode number 9. This is Dr. Jeremy Sharp. Welcome to another episode of the Testing Psychologist podcast. Today I am talking with Dr. Amy Connery. Amy is a board-certified pediatric neuropsychologist in the Department of Rehabilitation at Children's Hospital, Colorado, and an assistant clinical professor at the University of Colorado School of Medicine. She provides neuropsychological assessments and consultations in the Concussion Clinic, International Adoption Clinic, and Non-Accidental Brain Injury Care Clinic at Children's, in addition to bilingual Spanish assessments. Her research is in mild traumatic brain injury and validity testing in pediatric assessment, which we will definitely get into later on. Amy's most recently been involved in research examining neurodevelopmental outcomes after Zika infection and is currently in the process of putting together a grant and setting up services in Guatemala to do some assessments with Zika. Amy, welcome to the podcast.
Thank you.
Yeah. So I am really excited to be talking with you today. So just a little background. Amy and I have known each other for, I think it'll be 3 years this summer, which is hard to believe it's gone by that fast. But I initially contacted Amy as someone who could maybe provide me with some consultation / supervision on some neuropsych assessments. As I've talked about here before in the podcast, I'm, a quote-unquote regular psychologist who kind of went back after the fact and have been trying to really build neuropsych services and kind of do so in an ethical way. And Amy has really been a great resource along the way and provided, a lot of great consultation over the years. So super excited to have you here, Amy, and get into a lot of different things about your career and private practice and some of the work you're doing right now.
Great. Glad to be here.
Yeah. So it's awesome. So I wanted to start with maybe you could talk just a little bit about, kind of that classic question, why did you want to become a psychologist? And then, maybe talk a little bit about why specifically neuropsychology.
Yeah. So I think, my thinking around being a psychologist happened early and was pretty linear. And I came to neuropsychology in a really indirect way. And it was not something I knew I wanted to do as a younger person, and certainly even all through graduate school and my pre-doctoral internship, still did not know that that was something I wanted to do. But I came to psychology probably like many people. I was really interested in child development, attracted to the idea of a helping profession, and thought that I wanted to be a child psychologist who provided therapy. And so that is how I trained. I went to a very traditional psychodynamic graduate school and trained in that way. And then, in maybe my third year of graduate school, the training director was really encouraging me to get more experience in assessment. And I said, I did not want to do assessment. He said, well, if you want to be a good child psychologist, you have to be able to understand assessment, be able to read a report. And so you really need this experience. And so I did that in my third year externship and really, really loved it. I loved this sort of direct way that you would get a referral question, you would make a plan to answer the question, you would answer the question, make a plan to make things better. It was really a great fit for me in that way. So then from there, I proceeded thinking I was going to do therapy part-time and assessment part-time. And so that's what I did in my pre-doctoral internship and my postdoctoral internship. And then in my first job, that's what I did. A few days a week, I worked in a psychiatry department providing therapy and consultation to children and families. And then a few days a week, I worked in a hematology oncology department doing assessments. And as I was going, I worked there, I did that for 2.5 years and just really realized that I was very interested in the assessment part of it. it felt like a much better fit for me clinically with the way that I thought, with the way that I wanted to work, and it was going to be hard to do that full time without getting the extra training and assessment that I needed. So at that point, I quit my job, went back and did a 2-year postdoc in neuropsychology, and then from there sought board certification and my current job at Children's Hospital Colorado.
Yeah. So you're right. I mean, that's a bit of an unorthodox journey, I think, for most folks who end up boarded in neuropsych. Is that right?
Right, for sure. And I think that there are the generations ahead of me. I think it's much more common for people to have come to it from different ways and have gotten their training in some less traditional kind of ways too. But now, since 2005, we have what people may know as the Houston guidelines. And those were, well, I don't know if they were written in 2000. They may have been written before that. But basically what it states is that if you've graduated after 2005, there's some more strict parameters on the training that you need. And so we think the people before that time period had a little bit more leeway in how they were going to get trained to be board certified versus people coming out now. But some of that is also that now there's many more fellowships, much more opportunities for traditional training. And so that's the benefit. But again, currently now people are going down a pretty traditional route that's outlined in those Houston guidelines.
Yeah, for sure. I know that things have definitely changed, and it seems like a much clearer path at this point. Especially,
right.
Yeah, if you make that decision kind of early on in graduate school to really go the neuropsych route, it seems pretty well mapped out in terms of the training and the process. I am curious, this is an experience that I think paralleled my own in a lot of ways, except that I didn't, just quit my job and go back for respecialization, which is kind of a big deal. And, I want to ask you about that. But where did you do your pre-doc and your postdoc internships, just out of curiosity?
So I did my pre-doctoral internship at the University of California, the other C, San Francisco, in what some child psychologists may know of, with a woman named Alicia Lieberman, and she is a 0 to 3 specialist, a child trauma specialist, and a parent-child specialist as well. And we were working on doing a parent-child intervention, and at the same time providing assessment to babies, toddlers, preschoolers to see if we were getting any cognitive changes after a good parent-child intervention. So I was doing both things there. And my first postdoctoral internship was at the Children's Hospital in Oakland, and there I was primarily doing therapy.
Okay, I gotcha. So, I was actually going to say, so you kind of went, even on your pre-doc, and you were doing some assessment and were kind of focusing on cognitive measurement and that kind of thing. So I imagine that set you up fairly well going down the road. So let me ask you then, that the first time you described it, it was pretty quick, and you said, I decided to quit my job and go back for, my 2-year. Can you talk me through that a little bit? Like putting myself in your place? And I guess I have been in that place. I couldn't pull the trigger. Like that was a really hard thing to do. So help me understand how you made that choice, and was that hard? Any of that.
Yeah, I mean, some of it is just a little bit who I am. Like big changes are usually something I seek, and those things aren't really stressful for me or a big deal. But I think the biggest thing is that I was with my husband at the time, but we were not married and we did not have kids. And he is the same way, like picking up and moving was really not a big deal for him either. So we had some sort of the realities of our lives at the time made it such that it was not a very difficult thing to do. We didn't have children. We weren't pulling kids out of school. He wasn't in a job he loved. I mean, we had some things that made it really easy to pick up and go. For me also, I think I felt I was probably at that point, in my early 30s, and I knew very clearly that I wanted to do neuropsych assessment and that I probably wanted to be in a hospital, and that if I didn't get board certified, if I didn't do the requisite training and then couldn't get board certified, I would be restricted. And I knew I had, 30 working years ahead of me. And so to make a short-term sacrifice for the long-term goal of professional satisfaction seemed also like a no-brainer at that time.
I like the way that you say that. Yeah, short-term sacrifice for long-term satisfaction for what you knew you wanted to do. Yeah, I think it's easy for us sometimes to get caught up in the short term and let that be an obstacle to making what ultimately might be a really good decision. Especially with something like this where you did have to do any number of things, I suppose, to set yourself up to actually go back and respecialize.
Right. And for me, it feels it's so clear there, financially, was it the greatest thing to quit your job and do another 2 years of postdoc? No, but in the long term, I have been so much more happy than I was when I was also working as a therapist.
That's awesome. Yeah. So you kind of followed your dream and it's working. That's so cool to hear.
Right.
Yeah. Well, so I want to dig into just a little bit of the nuts and bolts around how you did that. Did you have to, well, I don't want to be presumptuous or anything. Can you just tell me what that process looked like when you actually decided to go back and respecialize? What did you have to do and what did that entail?
Yeah. So basically I wasn't feeling really drawn to the traditional 2-year postdocs. And I think, now looking back, I think that I was given a lot of misinformation, and I just had this sort of idea in my head about being an intern again after I had been working independently and I was licensed, and not having a lot of freedom in choosing how I was going to train and what populations I was going to train with, and being in this really prescribed kind of 2-year postdoc. So in retrospect, I think I had a lot of misinformation about that and misconceptions, and that would have been a good thing if I had just done the traditional 2-year postdoc, but that was my thinking at the time. And so what I did was because I graduated before 2005, I had some options. So I looked through, all of the postdoctoral internships that existed, and some that were not in the match, and found a board-certified neuropsychologist who was in private practice and also working part-time in a rehabilitation hospital. And so that's what I did. And my thinking again was that, and this was true, that I had a lot of control over, the patients that I saw, the experience that I sought out, and I was able to say, no to things I already knew how to do or knew I didn't want to do. So I did have quite a bit of control over what that 2 years looked like.
Okay. Yeah, that when you describe it that way, it does sound kind of nice. You had the experience and you found, a setting that would allow you to continue to grow and not feel redundant or anything like that. That's
right.
Great. So I'm just thinking about folks who might be listening now, maybe in a similar position, thinking about going back and maybe respecializing. What do you know what that would entail these days for someone who graduated after 2005? How would that process happen?
I do think that some people are still doing things like psych assistantships, but it's riskier because you don't know if that's going to pass muster with the Houston guidelines to allow you to be eligible for board certification. And the people that I know who've done it have done it with, real big name people and things like that. So I think the best way, or the quote unquote safest way, is to get into the match and do one of the 2-year fellowships that's offered through the match. And when I talked about my misconceptions about the match, I think that the people coming I had this vision of the young green intern. But the people coming into neuropsych postdoc are not young or green. They're people that have a lot of experience in assessment. And so the training is really at a high level. We have a postdoctoral fellowship at our hospital at Children's and our trainees come in with a lot of experience and then get a huge breadth of new experiences and training that I think would be really valuable, even if somebody was a little bit more mid-career or the beginning of career like I was.
Sure. Yeah, that's good to know. I know we've talked a little bit. I'm on the search for a pediatric neuropsychologist, and a lot of the resumes or CVs that I'm getting from folks who are in a private practice for their postdoc. I've noticed there are differences. Some of them do specify ABPP certified or ABPP eligible, to make sure that I kind of know, like, hey, this is the real deal, even though it's a private practice.
Right. And it's hard because people will try to figure that out beforehand. Like, if I don't do, a certified 2-year fellowship that's in the match, will this experience count or will that experience count? And they usually you can't always know ahead of time. So it is riskier for sure to do it that way in a postdoc that's outside the match.
Sure. Yeah. So your advice would be...
Well, I would say that the other thing is that, but people do that. I think people have moving fatigue. They move for grad school, they move again for internship, and they don't want to move again for fellowship. So we at Children's Hospital get large numbers of applications for internship, and then the number of applications we get for postdoctoral fellowship goes down by quite a bit. So there's definitely are people who are figuring out ways to stay and make it work in sort of these other ways. But again, I think that the experience is really valuable and the level of people coming in is really high, that even someone who's been working in assessment for a while could feel that it was worthwhile and worth their time to have done it.
Okay. Yeah, that's great. That's good to know. And again, folks who might be listening, I think we'll find that valuable just to know that training can continue and it can be really comprehensive and different. It's really cool.
Right.
Well, so, let me switch gears a little bit. I know, when we met, you had your job at Children's, but you also had a private practice. And, I'm using past tense. Well, I would definitely like to talk about how you transitioned out of private practice. But, I would like to talk with you about how you set up your private practice because it was testing specific, right?
Yeah, I just did neuropsychological assessment. That's it.
Right. So, talk to me about that. What was it like when you were starting your practice? I mean, were you working full time? Were you not? What was kind of your setup at that point?
Yeah, so we moved here to Colorado because we were having a family and we have some family here. And I had when we moved, just like a 1 day a week, PRN sort of as needed position at Children's Hospital in the concussion clinic. And I'm not really clear why, but I thought I wanted to do private practice at that point. So I thought, well, this is great. It'll give me a little bit of, I can keep my foot in the door of the hospital, get a little bit of hospital work, but I really want to do private practice. But I never did work at Children's 1 day a week. I didn't even work there 1 day a week my first week. I think I was 2, 3, 4 days a week almost immediately. And then within probably 6 months or so, it was clear to me that the private practice I liked it. It was, I thought it was rewarding in a lot of ways, and it certainly made a lot of sense financially. It was closer to my house, all these things. But I really loved the hospital-based work. And so within about 6 months, I took a 3/4 time position, salaried position at Children's. And about 2 years after that, I took a full-time position at Children's and then transitioned out of my private practice. But setting up my private practice in Boulder was, I would say, very easy. I bought a few things new. I bought everything else used on the listservs. I got office space pretty easily.
Can I interrupt you there?
Yeah.
Sorry. Yeah, I think that's actually really important. And, I did an episode a little while back just on how to finance a testing practice. So, could you talk a little bit more about how you kind of set aside money or, knew how much you needed to spend and these listservs, which listservs did you get your materials from? I'm curious about all that.
Yeah, I think that I cannot remember exactly, but I think I might have gotten mine on the AACN listserv, which is the listserv for board certified neuropsychologists, and it's adult and peds people on it. But certainly the pediatric one would also be a great place because there's many more people on that listserv. I didn't really, people were telling me, you need $20,000 to start a practice, you need $30,000.
Okay.
And I luckily didn't listen to them because that was not true for me. I know some people would say that, but that was not true for me. I got a reasonable rent on office space. I bought nice furniture from IKEA, all my office furniture from IKEA.
Oh, yeah.
And then I had a full battery of tests. I added things as I went, but I had enough to do full battery with mostly used things that were in good condition. And so I spent much closer to about $7,000 to get up and going.
Okay.
And I had cases right away. So within a month and a half or something like that, I had paid that money back.
Yeah, that's fantastic. I think that's one thing, people get scared with the cost of admission, so to speak, but it comes back pretty quickly if you're charging for your evals in what I would say the appropriate way.
Exactly. And some people will do things like, another neuropsychologist moved to our area and I was only using my office 1 or 2 days a week, and she wanted to do a little private practice. So she rented my space and my testing equipment from me while she got hers up and going. So that's another thing people do. Most people don't use their office 5 or 6 days a week. And so you can often, if you want to start to get referrals and not invest until you have a steady stream of patients coming in, do something like that and rent somebody else's space and equipment.
Yeah, that's a great idea. I like it. Let me ask you about if you're willing to share, how did you structure the rental cost for her to include both the office and the testing materials? Were those separate numbers, or did you pull it all into one kind of fee, or how did you do that?
We, how did we do that? I know we did the rent just per day. So if we said, okay, it's, 25 days a week, then we just split it by, I'm here this many days, you're here this many days, and split the rent. Mm-hmm. Oh, and I'm so sorry, cannot remember what we did about the testing equipment.
Okay.
And then, but the protocol seemed really complicated. So she just bought hers and I had mine. I think we thought it was going to be way too complicated to figure out how much money she would have spent by using my protocols. So we kept that separate.
Okay, I see what you mean. So she used your test kits, but she bought her own response booklets and answer sheets.
Exactly. It just we thought it through, and it just would have been very difficult. Like days where she sees, a 6-year-old and does much less testing. She does a 16-year-old. Like, how are we going to figure out how much she owes for all of that? And so we did that just totally separately. She did use I had an IVA, a continuous performance test that I was paying for per administration, and she just kept track of that and then added it to the rent.
Okay, I gotcha. So, yeah, that sounds good. That's something I think to consider for anybody.
Very smooth way to start that way. Really smooth for her.
And so, going back just a little bit, when you said that you had enough to do a full battery, could you run down just the tests that you felt were absolutely necessary to get up and going, where you could do what you needed to do right off the bat? What measures did you get?
So I cannot remember if I had a WIPSI right away. I must have had a WIPSI right away. Sorry, this has been a little while. I can't remember. But a WISC. A WISC, the Wechsler Intelligence, the WIAT, the Individual Achievement Test. What else did I have right at the beginning? I had a RAY, complex figure. I had a RAML for memory testing. I had an IVA for continuous performance attention test. I had the DCAFs. I had the NEPSI. I had groove pegboards, the groove pegboard. Mm-hmm. And I had some rating scales. I had the brief, the BASC, the Vanderbilt.
Mm-hmm.
I had the VMI. And I think those were the ones that I started with.
Okay. I know you didn't mention this, did you happen to have the ADOS? Were you doing autism?
Oh, I did have the ADOS. Thanks for reminding me. I did have the ADOS because my second referral was for an autism evaluation.
Ah, yeah. Okay, so yeah, that's a pretty comprehensive set of materials. I imagine you were good to go with most things that came your direction there from the beginning.
Yeah. And then I just added a few little things. I added, the test of word reading efficiency, and I added the CTOP. But I did pretty well with what I had for a long time.
Cool. And how did you get referrals? I mean, you didn't go to school in Boulder. It doesn't sound like live there for very long before you had your private practice. Is that right?
Yeah, we had been living in Utah, which is where I did my fellowship, my neuropsych fellowship, and I sent out a letter introducing myself to the local pediatricians. And I had not been in Colorado. We got here. We were staying with some family. We didn't have a place to live or anything like that. And I had been here maybe 6 hours when I got my first phone call.
Oh my gosh, that's wild.
Yeah. So I hadn't found an office yet. I mean, yeah. Or I hadn't set up my office. I had found my office. We had come on a trip a few weeks earlier to get the office. So that really, Boulder, it was, we have so many providers in some ways, but not that many people doing assessment specifically. And I did no marketing from there. If I had wanted to grow it, I would have had to do more marketing than that, but I didn't. I could be steady at, at the beginning I was seeing two kids a week about, and then I went down to one kid a week and seeing that really low volume of kids. It just was steady. Then parents telling other parents. I got referrals. A few pediatricians kept me on their radar, and I got a few from them. Some child therapists, and then a few reading tutors and like study skills executive coaches kinds of folks who would regularly refer to me also.
I hear you. Yeah. So it sounds like a lot of really word of mouth more than anything.
Yeah, it was really word of mouth. And I would say the pediatricians, the reading tutors, the school psychologists, the executive coaches, those were the big ones. I think sometimes people think about psychologists and child therapists and stuff, but I know a lot of those folks, but I don't think it's as much on their radar as it is those other people. So that was really the best bang for your buck for me.
So I've said before that I think that our reports are one of the greatest marketing tools that we have. I wonder if that felt true for you as well. If you really put time into your reports and put some effort into that, or if you had other ways of following up with those professionals to kind of keep the referral stream going, or what?
Yeah, I think that yes, I agree with you about what you're saying with the report, and I also would say that longer does not mean better, and certainly for a busy pediatrician is not going to read a 15 or 20 page report. They're probably not going to read an 8 or 9 page report. So I tried to keep the reports brief and user friendly. And then when I sent them to the pediatrician, I sent a quick summary letter. So nothing long, just a short thing. Thank you for the referral. I saw this kiddo of yours. These were my 2-3 initial findings. I asked the family to come to you for a med consult, or the family will consult with you as needed, but the primary recommendations are for school-based intervention or something like that. So just a 1-paragraph letter, so they could throw the report in the chart and then have that letter to say oh yeah, look at this. This was, these are kind of the results of the evaluation, and these are the action items for me, and don't have to sift through the report.
That's great. Yeah, good point. I think that's a challenge and something that people are always wondering about. How do we communicate our findings but do it in a way that people will read, especially pediatricians? So Those are
Right, right. Because
great
the
things.
pediatricians are not going to read a long neuropsych report. They're too busy.
Sure, sure. Yeah, so I know that, gosh, we've been talking for a little while here. I'm a little conscious of time, but I really wanted to ask you, switching gears again, about validity testing and performance testing for kids. That's a major research area for you and something that I think is really important. So I want to leave it kind of open. Can you just maybe talk about how you got into that as a research area and what you're finding and yeah, kind of maybe best practices with validity testing with kids?
Yeah, I think I got into it and interested in it starting to work in a concussion clinic at Children's Hospital where I'm working now. And when I got there, they had already had been running for several years, had several years of data, and we're finding consistently that in the context of that clinic, mostly teenagers referred for prolonged symptoms after concussion, that consistently every year between 15 and 17% of kids were failing performance validity tests or symptom validity tests, as we sometimes call them. Right. So what we were doing then was having to provide feedback, give feedback to parents about what happened and why, and think that piece through. And since then, we've also done research on, well, what's the outcome? What's the patient outcome for a kid that failed performance validity testing and a kid who didn't? And we're finding that they're all getting better. Those kids are getting better at the same rate as kids who gave a valid, credible performance during the consultation. So it's been really fascinating for the amount of times I've seen a kid fail and had to give that feedback. It's just much more than you would see in any other setting, probably. And so again, we've done a lot of research on why that happens, what happens afterwards, using it as an important intervention in another way of helping to understand the kid, the prolonged symptoms, and how to help the kid to get better, and help the parents understand the etiology of the symptoms and how to help the kid get better. And then recently we also published a model for providing feedback, because a lot of practitioners are worried about using symptom validity testing, because if the kid fails, then what do you say to the parents? And does it feel like you're confronting them and very difficult? And it usually doesn't feel that way. And so we published a paper in the Clinical Neuropsychologist that provides, kind of a decision tree model of how to conduct those feedbacks so they feel really productive for the provider, and that most importantly, they're productive for the families.
Yeah, I think that's super important. And we will link to that article in the show notes and try to help people access that. Could you talk through that quickly? You say there's a decision tree as to kind of how to do that. Could you kind of give an overview of what that looks like?
Yeah, we basically, what we do is we do it with the child out of the room first, because we want to be pretty direct and frank with the parent, and the kid knows what happened. We don't view it as an unconscious process, but we do view it as important clinical information about other non-neurologic factors or psychological factors that are contributing to the persisting symptom presentation of the kid. So we try to take it very seriously, and we present it to the parents that we give when we do these kinds of evaluations. We give tests that help to tell us if a child is really trying their best to do well, because we want to know if we have low scores, if those represent potentially true deficits, or might just be because the child wasn't trying their best to do well. And then we say, your child did not do well on those tests. And then we kind of leave it open, and we have really found over the hundreds and hundreds of kids we've seen, parents say, oh yes, that makes a ton of sense. I've been thinking that myself. Sometimes they don't understand, and they think, well, she never really tries, that it was sort of a withdrawal of effort rather than it was a concerted effort to do poorly, which is more how we view it. then sometimes people feel like, well, if my kid has, headaches or other sorts of pain, that would have contributed, that would have made them score low on those tests. Or if my child is so impaired that's why they scored really low. And so then depending on how they answer, we really kind of try to talk through with them about the nature of the test without giving a lot of specific information, or certainly without naming the test, what that, that pain isn't impacted. And when kids, even people with more serious neurologic illness, generally pass these kinds of tests. So those things aren't the reason. We try to help them really understand from a place of empathy and not be frustrated or angry with the child. And then when it feels like they have made some sense of what happened, then we try to really sort through, like, well, what do they think is happening for the kid that this happened? What stressors are getting in the way? What's happening? And we have that conversation with the parents, and then try to make a plan to have things be better. And then at that point, we bring the child in and speak about it in a much more soft and maybe a little bit of a less direct way. We never have kids cop to it. Kids never say, "Oh yeah, I did that." But they don't. Every once in a while, they say, "No, I didn't," or get a little bit argumentative, but not frequently. Usually, they kind of are quiet and nod, and then we talk through the treatment plan that we discussed with the parents.
I see. I know there's some debate out there, I could guess maybe the answer to this, but do you just throw out the data for the eval if the kid fails, or how do you consider the data from that point?
Yeah, we do a few different things throughout our concussion evaluations are very abbreviated, so they're usually between an hour and 15 minutes. And we have a few standalone measures and a few embedded measures. And if things look concerning for effort throughout, then we do not report any of that data. None of it gets reported.
Yeah. I really like how you discuss that model, and it seems like a fairly collaborative approach to something that could otherwise be conflictual, potentially. So
Right. And again, I think it's because, again, our approach is that this isn't, some people I think, oh, the patient failed effort testing, so I don't have any data. I throw out all my data. And we don't approach it like that. We approach it like, now I have a very important piece of data. And this piece of data tells me that there are other non-neurologic factors that are at play here. And we have to understand them in order to help the child. So I think coming from that stance, that helps it to be collaborative and supportive for families. And again, in our research, we're seeing that it's just as a helpful intervention as when kids provide credible data.
That's really cool. That was really cool. Awesome. Well, I know that y'all, you're in a hospital setting and doing primarily concussion evals. Do you see any value for validity testing in private practice with kids?
Oh yeah, for sure. I mean, I probably do like 30% of my practice at the hospitals with concussion, and so I do a variety of other things. And in my private practice, I did use validity testing, and then when I do comprehensive full evals in our regular general rehab clinic, I also do validity tests. I see failure on those less frequently, but I do see it enough that it feels really valuable to be doing it, and a concern to not be that you might be missing something really important.
Yeah, absolutely. I feel like this is it's such a big topic. We could probably do a whole episode just on validity or performance testing in kiddos. But yeah, I appreciate you diving into it a little bit. And like I said, we'll have a link to your article in the show notes, and give people a chance to check that out. Because I think it seems like you frame it in a really nice way that can be helpful for families. So thank you so much for the time. I know that, we've spoken for quite a while here, and gosh, I feel like we packed a lot of really good and helpful information into this time. So I don't want to take too much more of your time, but anything else that you would like for folks to know, anyone who might be getting into private practice with testing, whether that be business-wise or validity testing, anything that you wanted to share kind of as a last note?
Well, I think that, for me, one of the main reasons for me to go back to get that additional training was I just wanted to be good. And that's the advice I would give. If you're going to open a private practice or, work as a staff member at a hospital and whatever you're doing in terms of therapy, but certainly if you're respecializing, get the support that you need, the supervision and the training so you can be good at it. And I think that benefits all of us in the profession when we have people who have our similar degrees and training are doing good quality work.
That is fantastic advice. I love that. Well, Dr. Amy Connery, thank you so much for spending time with me here today and running through all these different important pieces of private practice and working in a hospital and respecializing. This has been really fun.
Yeah, thanks for having me.
Yeah, take care. Bye-bye. Hey, everybody. This is Jeremy again. Thanks for listening to my interview with Dr. Amy Connery. She talked about a lot of really cool stuff. She's had a really interesting career so far and continues to do pretty cool things there at Children's Hospital. Amy and her team have written a number of articles actually on performance validity testing. We talked about her most recent one that frames how to give feedback for failed validity testing. So you can definitely check that out in the show notes. As always, if you enjoy our podcast, please take 30 seconds to go into iTunes or wherever you listen and subscribe, rate, and if you have a minute and you're feeling kind, give us a review. That'd be awesome. If you want to talk with other testing psychologists and join our growing community, you can go to thetestingpsychologist.com/community, and that will take you to our Facebook group where we're having some kind of cool discussions about technology and time management and lots of things that are pertinent for testing. So thanks, as always, for listening. And, we have some cool stuff coming up. I think here in the next couple weeks, I'm going to be talking with Dr. Megan Warner out in Connecticut about therapeutic assessment. Going to be talking about how to do a good school observation and all sorts of other good stuff. So y'all take care, and we'll catch you next time.